Welcome to another one of my videos. This playlist is going to be all pharmacology. Today I'm going to do maybe a 5 or 10 minute one on just the basics of pharmacology. And this is applicable to lay people, EMTs, AEMTs, paramedics. It is not going to be a super in-depth exactly what happens at the cell wall or at the endoplasmic reticulum. If you want that, you can find that. This is just a short, sweet, how it works for us in the field and things that we should think about. And I guarantee the EMTs and AEMTs, unless you've taken my class, there's a portion of you that have never heard any of this. And paramedics, how long has it been since you went to medic school? Okay, so it's a good refresher for everyone. Excuse me. And if you're a layperson, it's a good lesson on how drugs work within our body, how we take them in, how we use them, how we get rid of them. So I've got some things on the board. We're going to go through these, and then I'm going to have a bunch of shorter videos on different drug classifications. My first one is going to be antiemetics. I'm a huge believer in the use of antiemetics in EMS, and I think we don't always make the best decision when we have a choice of which ones that we can give. So let's start with just some basics. Pharmacodynamics. This term is how that drug works and how we expect the body to respond to it. Okay, so within our body, within our cells, we have receptor sites typically. On the outside of our cell wall, so our cell wall is a little, we'll call it a circle. Not all cells are circular, right? But we'll call it a little circular membrane. And within that, or on top of that, there are protein coatings. And generally these drugs bind to it or attach to it, and that then stimulates a chemical reaction. And we get that desired or undesired effect from it. Okay? Now, potentiation. This is how one drug can make another drug work better or work more, the enhancement of that second drug. So morphine, great pain med, right? But if you give something like Phenergan with it, which is an antiemetic, morphine will actually work a little better in some cases, okay? Barbiturates, downers, central nervous system depressants, the benzodiazepines, Ativan, Xanax, Valium, Verseds, right? Do not take with alcohol because it potentiates the effect of that benzo. So you might take one Xanax every 4 hours for anxiety, but if tonight you take it and drink a 12-pack, good chance you're unresponsive and puking on your own vomit, okay? So the potentiation of a drug by another drug. Then there's refractory. That's when your body is not responding the way we expect it to. If you're an EMS or nursing, ER, whatever, one of the terms you hear from American Heart Association all the time, refractory VFib, refractory VTAC. If it's refractory, do this. Bronchospasm for your asthmatics, refractory to nebulizers, mag sulfate, and then epi, and other options at that point. So refractory. Synergism. Synergism, the best way I can explain this is regular math is 1 + 1 = 2. That's standard reaction of a drug. This drug, and this drug gives us this two effects. Synergism is Viagra, Cialis, any of the ED meds, plus a nitrate for chest pressure. That's 1 + 1 = 5. Okay? Because the sum of the two drugs together are so much greater than in individual dosings. Therapeutic action. Okay? The therapeutic action of a drug is the intended action of that drug in that approved setting. So the therapeutic action of albuterol, whether it's a nebulizer or a multi-dose inhaler, is bronchodilation. Okay? excuse me. Therapeutic threshold is the amount of that drug that's required to get that therapeutic action. Some of them are very short. You look at epinephrine. Epinephrine, 3 to 5 minutes. You look at some of them, if we go down the path of asthma, albuterol, right, 3 to 5 minutes. But theophylline, which is a pill, well, it can be given IV too, but typically at home people, this is an old school drug, but theophylline could take days to weeks. A lot of your psych meds, the tricyclic antidepressants, can take up to 2 weeks for them to build a therapeutic threshold for that drug to work. Now, therapeutic index is the difference between the therapeutic threshold and the amount that's considered toxic. And in some medications, it's very, very small. Digoxin, a great example of this, a drug that used for atrial fibrillation. And digoxin on lab values is like 10.2 to 10.6. Anything above it is toxic. Anything below it is subtherapeutic. Okay, so the therapeutic index, what is safe and effective range. The tolerance to it. Tolerance is sensitivity to a drug. It could be the drug itself, or it could be the rate of administration of that drug. We know that narcotic addicts, your heroin users, your fentanyl users, your carfentanil users, each time, or in a relatively short period of time, they have to take more and more and more of that drug to get the same high. Okay, that's tolerance. That's building a tolerance. You know, you start out taking 1 Motrin for a sore back, and it works great. 3 weeks from now, you're now taking 4 because you're building a tolerance to it. Okay. Now, untoward effect and or side effect. I think of these as the untoward effect. The technical definition is a side effect of a drug that's harmful to the patient. Side effects can be just common things that aren't really harmful. Side effects to albuterol inhaler. Oh, you might be a little jittery and a little nervous, right? Because the drug is working on your sympathetic nervous system. But an untoward effect, a dangerous side effect would be, if you take nitrates with your nitroglycerin, with your Viagra, it'll cause an unsafe drop in blood pressure and actually kill you. Okay? Now, absorption is the movement of that drug from however we took it in. There's all kinds of terms for this, but if you just kind of think of it how we do things orally, IV, intravenous, IO, intraosseous, IM, intramuscular, IN, intranasal, subcutaneous. We don't really do much subcutaneous in the field, but patients at home do. Right? They take some of these injectable blood thinners and they take their insulin subcutaneous. So what is that absorption? How does it get from point A in my shoulder to point B in my heart to point C to my bronchioles and my lungs? Okay. The distribution is the manner in which that drug is then transported. Okay. These things are transported by the circulatory system. And I mean, it doesn't matter. You inhale it, it gets absorbed in the circulatory system and distributed. This is influenced by a lot of things. Perfusion being the biggest one, right? You have a cardiac arrest and you give epi IV, but you're not doing chest compressions. There's no circulation. That epi sits in the arm. Does no good at all. Okay? So cardiac output, perfusion. Is that red blood cell? Is that oxygen molecule? Is that glucose molecule? Is that epinephrine getting to my big toe, or is it sitting someplace? Right. So what affects cardiac output? Heart rate. Too fast. It's pumping too fast for the heart to pre-fill with enough blood to then pump out effectively. If it's going too slow, it's pumping blood, but it's just not pumping enough of it at a speed that we need it to. Your blood pressure, right? Vessel's too big, hypovolemia, not enough volume. Anything that would cause your blood pressure to be low would affect perfusion of these and distribution of these drugs. Ejection fraction. Holy crap, ejection fraction. So the amount of blood that we take into the right atrium, let's call it 75 mLs. Okay? We should be pumping out roughly 45 of that. Okay? So we take in 5 or 6, let's say 5 tablespoons of blood, we should be pumping out roughly 3 tablespoons. So ejection fraction. Not all of the blood gets squished out with every contraction. But the more failure you have in your heart of your left ventricle, the less gets pumped out, the lower your ejection fraction. Therefore, the less fluid you're moving through the system. Therefore, the less distribution. Now, there are a few physical barriers also. Blood-brain barrier. Excuse me. Blood-brain barrier is kind of interesting. It's a protective layer around your central nervous system. And what this is supposed to do is protect your central nervous system from pathogens. So it limits things that can get in. It also limits the availability of antibiotics into your central nervous system. So these central nervous system infections get really bad, and we have a hard time fighting them because of your blood-brain barrier. Now, the other thing your blood-brain barrier does is it allows things to cross without assistance. Right? Oxygen goes in, carbon dioxide comes out, glucose goes in, and glucose in your does not need insulin to cross your blood-brain barrier. Now, your blood-brain barrier will have an impact on your metabolism, on your amount of energy, on how you store or use fats and glucose. The funny thing is they also think it has an effect on Alzheimer's. Okay? So blood-brain barrier. Also the placental barrier. So some drugs cross into and can harm a fetus, and some things won't. Okay? So those are some factors that affect distribution. Now, biotransformation is how much of that drug is brought in and then inactivated and eliminated before the bioavailability. So bioavailability is the amount of drug, I forgot to write it on the board, but bioavailability is the amount of drug that's available at the receptor site. Okay, so that biotransformation takes the drug, processes it for availability, processes some of it for waste. So rate of biotransformation depends on how often you give a drug. For example, epinephrine is recommended to be given every 3 to 5 minutes because biotransformation of epinephrine takes somewhere between 3 and 5 minutes. Which makes me go, because the New Hampshire state EMS protocols call for epinephrine after every 2-minute cycle of CPR during cardiac arrest. So that, so we're giving it sooner than is required. It's not going to be available right now, but the sooner we get it on, in theory, right, the sooner it becomes available through biotransformation. Okay. The most common place for this to occur, biotransformation, is in the liver. So people with liver failure have trouble with biotransformation. So a drug, let's say heroin. Let's go with a prescription drug, Percocet. I have a healthy liver. My liver biotransforms an amount of that Percocet out of my system and makes a certain amount available at the cell. And this is what they base dosing on. If you have liver damage, liver failure, you take the same amount of Percocet I do, you're going to have a stronger reaction to that narcotic, and you're at a significantly higher risk for toxic ranges, toxic effects, and overdoses. Now, excretion. How do we get rid of that drug and that waste from our body? Primarily, it goes out through our kidneys and out through our urinary system. However, our liver gets rid of some of it, which puts it into our bloodstream. Our lungs get rid of some of it, so we exhale some of it. We absorb some of it and get rid of it through our intestinal tract and our feces. We sweat some, and then for our pregnant females or our breastfeeding females, they get rid of some of it through mammary glands. That's why we're so nervous about our women pregnant. When was your last period? Any chance you could get pregnant, right? And will we hurt the fetus, or will we hurt their baby that they're feeding? Now, we have another two terms here, agonist and antagonist. An agonistic drug, an agonist works with that nervous system. And we'll come back to that in a minute. Antagonist works against it. So the most common antagonistic drug we use is Narcan, right? It goes out to the cells, and those protein on the cells, those receptor sites, have a stronger affinity for Narcan than it does the narcotic. So it grabs the Narcan, holds onto it tighter, boots the narcotic off. So that's an antagonist. Now, when we look at drugs and how they work, we've got to look at the autonomic nervous system. And this is just a short piece on this. I'm going to do a 5 or 10 minute blurb on this as well on another video. We have afferent and efferent systems or divisions. Afferent is moving inwards or towards the central nervous system, and efferent is away. So I touch something hot, that nerve impulse is traveling through an afferent stream towards my brain to say, ow, pull back, and that a reflex, it pulls back. I want to reach out and take a sip of my water, then the efferent system allows that message to go from my brain out to my bicep, my forearm, my fingers, grasp my water, and take my drink. What we need to think about is the autonomic nervous system is the fact that it's involuntary. Cardiac function, our body temperature, smooth muscles in our pulmonary system, in our GI tract, glands, and then arterial blood pressure. I mean, this is involuntary. Think about this being a skeletal voluntary instead. You would have to concentrate from the moment you started to swallow until the moment all the food had passed you, everything, and out the backside. If it was voluntary, that would suck. So involuntary are just that, involuntary actions. Now, our autonomic is broken down into two systems, sympathetic, parasympathetic. So sympathetic is fight or flight. We release a ton of chemicals into our body, epinephrine, norepinephrine, dopamine, cortisol, and it allows us to fight to the death or turn and run faster than we've ever run before. It's a safe condition to be in a sympathetic environment internally for short periods of time, right, until you get out of that emergent event. But then your body has to relax and go back to normal. That's where your parasympathetic nervous system comes into play. So sympathetic, fight or flight. Parasympathetic is rebuilding and returning to normal. One of the terms for it is breed or feed. So you're fixing, you're repairing, you're rebreeding damaged tissue, and you're feeding cells that got malnourished basically during this fight. Right? You need to refeed the oxygen. You need to refeed the glucose. Now, in the sympathetic nervous system, the neurotransmitter. So a neurotransmitter is that chemical that goes from one cell to the next cell and tells it what to do or triggers it to do something. So in the sympathetic nervous system, it's epinephrine and norepinephrine are the two primary chemical facilitators or neurotransmitters. In the parasympathetic system, that vegetative, getting everything back to normal, that primary neurotransmitter is called acetylcholine. Okay? So if you have a drug that works with a system, If it works with a system, mimetic. If it works against the system, it's a lytic. A sympathomimetic drug, epinephrine, works with the sympathetic nervous system. A sympatholytic works against it. A parasympathomimetic works with the parasympathetic nervous system. A parasympatholytic blocks the parasympathetic nervous system. So blocking the parasympathetic nervous system, when would we want to do that? Well, if the parasympathetic nervous system has kicked in for whatever reason and slowed your heart rate down, vagal event, we can give a parasympatholytic, atropine, to block it and allow your heart rate to come up. If we gave epinephrine, we would make the heart rate climb, but the parasympathomimetic, the parasympathetic system, would be fighting that to keep it slow. So you give atropine to allow it to come back up. In the nebulizer world, or inhaled medication world, albuterol is a sympathomimetic. The ipratropium bromide, or Atrovent, is a parasympatholytic. This parasympatholytic does not cause bronchodilation, but it allows the sympathetic system to work easier and more effectively. So we give a sympathomimetic drug, albuterol, to try to force the bronchioles open, and we give that Atrovent to block the parasympathetic nervous system to allow the albuterol to work better. Now, there are a bunch of classes of medications. As I do each class, each short little blurb on each of these different classes of drugs, I'll touch on these things that we've already talked about. The distribution, absorption, distribution, biotransformation, bioavailability, the therapeutic levels, the dosing, what class of drug, if it falls into that. Okay? We're going to talk about anticoagulants. We're not giving them in the field. Oh yeah, we are. We're giving aspirin, right? But when do we worry about these? And what kind of patients are taking them? When don't we give our aspirin? Anticonvulsants, antidiabetics, dysrhythmics, hypertension meds, psychotics, cardiac meds, steroids, gastrointestinal fluids, NARCs, respiratory meds, sedatives, and vasoactive agents. And when I do the vasoactive agent, we're going to spend a few minutes talking about that in the realm of PIFT, paramedic interfacility transfer, as well. There's a little bit of confusion about when we can't take somebody. So anyways, during these classes, I'm going to refer a lot to studies. I will also refer to ER practice, and I will also refer to the New Hampshire protocols. I know the New Hampshire protocols are far more aggressive than a lot of states, but I also know that a lot of the states are utilizing our protocols now as their basis. So with each of these videos, after I do it, after I edit it, in the description of it, I will put in how many minutes towards pharmacology this is for you to utilize for Con Ed. If you have any questions about any of this stuff, please shoot me an email, emsabounds@gmail.com. If you leave some comments, I'll try to get back to you or try to answer them there as well. I do ask, though, if you watch my videos, or all I ask really, is that you subscribe and you hit like and pass the word around. Again, these are free. Anybody can use them. You can use them for Con Ed, or you can just use them for general knowledge. Okay? So thank you very much, and I thank you for joining me from the lovely Hillsborough River State Park in Thonotosassa, Florida today.